Okay, like I was saying, I'm in my first year as a psychiatry trainee in the Northwest, and today I'm hoping to give you a little bit of what psychiatry tastes like, so to make your psychiatry rotation a little bit less daunting. Okay, so let's get started. So let's just get right down to it. So let's first talk about the types of psychiatric placements, right? So in psychiatry, in the NHS, we have two types of placements. It's either inpatient during a psychiatry ward or a community placement in the community where you see patient in clinics or do home visits, that sort of thing. So I'm gonna be focusing mainly on inpatient experience because I've noticed most of you guys are GP trainees, so you won't. I doubt you'll be placed in a community placement. It's very rare. So we're just gonna focus on the inpatients. But if you have any questions about the community placements, I'm happy to answer them at the end of the presentation. So the type of inpatient psychiatry wards we have are listed in the slides. So first you have the general adult wards, which is the bread and butter of psychiatry. In these wards, you'll see the most common psychiatry presentations, like, for example, bipolar, mania, psychosis, schizophrenia, severe depression, that sort of thing. They usually consist of patients aged 18 to 60. Sometimes we have patients a little bit older than that. It really depends on the presentation of the patient. The second type of ward is older adults. So here you will mostly see patients 60 and above, sometimes younger if they are presenting with dementia. So here you'll see cases of dementia, all sorts of dementia, such as Alzheimer's, frontotemporal dementia, Lewy body dementia, that sort of thing. Sometimes you see young patients like in their 40s with Lewy body dementia, which is very sad, but they do get admitted into the older adults or the dementia wards. In these wards, you'll face a lot of physical health concerns. It will be mainly focused on the physical health concerns, actually, because of the demographics of the patients. Um, so as GP trainees, you'll most likely be placed in one of those two wards at the top, whether it's general adults or older age psychiatry wards. Sometimes you get placed into other placements, but like I said, it's very rare. I haven't seen a lot of it. So yeah, but as psychiatry trainees, I'm not sure if anyone here is studying psychiatry, but psychiatry trainees can get placed into anything, obviously. The next type of ward we have is the PICU, where as a GP trainee, you might have to deal with during your own calls as well. So PICU basically stands for Psychiatry Intensive Care Unit. This is a ward that's usually has much more security, more staffing, more restrictive options, and they're usually for patients who are severely agitated or severely aggressive, or maybe severely depressed or catatonic, that sort of thing. The next type of work we have is forensics. These are people with mental health problems that have problems with the law, touchings with the police, that sort of thing. As a junior doctor, you don't really get involved in those kind of legal side of things. You can do if you're interested, but you mainly treat it as a general adult ward. There are many types of forensics wards. They have low secure, medium secure, high secure. Yeah. Um, so I just wanted to say something, guys. I've been told repeatedly that sometimes I tend to speak very fast while I'm presenting. So if that's the case, feel free to stop me at any point. Don't worry about it. Okay, so the next type of wards we have is the child and adolescent mental health specialty. So these deal with basically people with mental health problems below the age of 18. Um, or sometimes even below the age of 16, really depends. Here you'll see lots of different presentations like anxiety, depression, sometimes eating disorders as well, that sort of thing. ADHD as well. The next one we have is the perinatal. Perinatal is basically the link between obstetrics and psychiatry. Sometimes it is next to a mother and baby unit and it deals with, well, you've guessed it probably, perinatal psychosis, depression, and to help any mother that has a problem with bonding with her child, basically. The next word we have is the learning disabilities or neurodevelopmental. So these they mirror the CAMS specialty, but they only deal with autism or learning disabilities, that sort of thing. We don't have a lot of inpatient units for learning disabilities, but there's a lot of placements of them in the community. And then the last is the community teams, like I spoke about in the beginning, and liaison. So liaison psychiatry is basically where acute medicine and psychiatry meets. So as psychiatrists, we get a lot of referrals from everywhere. You can get referrals from GPs. You can get referrals even from members of the community if someone is causing major disturbance. And if these are not severe enough, they're usually dealt with by community mental health teams, home-based treatment teams, that sort of thing. But if a patient is admitted in a ward or a patient has already went to A&E because of the severity of their, you know, disorder, when they get referred to us, a liaison psychiatry team has to see them inside the hospital. So this is a very fast-paced type of psychiatry specialty where you have to make very quick decisions, you have to make very quick assessments, and you work very closely with acute medical team. So it's very interesting, and it's usually reserved for those ST3 and above grades. So this is the type of psychiatry placements, just to give you a taste of what to expect. So what to expect on the wards. So like any ward ever that existed, we have handovers, MDT meetings, ward rounds, that sort of thing. Let me just show you how a psychiatry ward looks like. Because when I first entered a psychiatry ward, I was a bit surprised of how it looks. It doesn't look like a regular medical ward that you might have visited. So basically, a psychiatry ward is a very big ward. The beds are not just stacked together like in medical wards. Each patient usually has their own room with their own bathroom. And there's usually communal areas where we can plan activities just to, get those patients into a social routine and obviously make their mental health better. We also have interview rooms where we conduct the morning ward rounds and the MDT meetings. So what happens every morning is that, of course, we get a handover from the night team with if there's anything urgent or anything that needs to be done. And then we start the ward round. But the ward round of psychiatry is a bit different than medicine in that we don't go to each patient's bed and just start, talking about them. That's not how it usually goes. So psychiatry reviews take a very long time for obvious reasons. So you can see the patients sometimes an hour, even two. So what usually happens is that you review only a few patients every day, and patients have scheduled reviews. So for example, a patient will get seen once a week by a consultant. So you divide the days on the number of patients you have, and each day you see a handful of patients. And usually patients get called into the interview rooms or the MDT rooms. We don't go see the patients in the rooms. So that's for a morning handover, just to give you, just for you to imagine how it's usually like. So, be prepared in the morning with a cup of coffee because it's going to take a long time and there's going to be a lot of documentation involved. Your other duties on the ward as a junior doctor during the day team or even during the on-calls is clerking new admissions. So psychiatry clerking obviously takes a very long time and you have to spend a lot of time with the patient, taking the history, doing the mental state examination, which I know you all would know what an MSE is, but there's a little bit of a refresher on the next slide. You also do baseline investigations because our drugs are very nasty. They cause all sorts of metabolic changes and side effects. So you have to have a baseline for medications when a patient is admitted in case their medications are altered or they're started on antipsychotics, for example, that sort of thing. You have to do mental capacity assessments all the time. You have to get really good with MCAs when you start psychiatry because it's basically the only thing we do on the wards. And also as a psychiatry junior, you also liaise with families a lot, with GP a lot. You get involved in the patient's personal life. So on the wards, we usually have admission meetings with the family, and then progress meetings while the patient is admitted, and then discharge meetings. Of course, provided that the patient has capacity and is happy for his information to be shared with his family. So there's a lot of family meetings. So you have to develop that sort of communication skill with families and relatives. And obviously managing risks because psychiatry patients are very unpredictable and they come with risks to themselves, risks to others, that sort of thing. Observation levels. When a patient is admitted, you have to decide with the nurse, based on his current presentation and his history of risk, what sort of observation level he should be on. You'll get introduced to these very thoroughly in your local trust induction, but whether a patient is like one to one, so the patient has to be observed maybe every hour Or maybe as a patient is 2-to-1, where two members of staff have to keep an eye on the patient at all times. That sort of thing. So like I said, you guys are oral doctors. I'm not just gonna start explaining the MSc and the Mental Capacity Act for you now, but a little refresher before you start psychiatry word would go a very long way. As you all know, the mental state examination is not an examination that takes place on its own. It's basically something you do alongside history. So you speak to the patient, you ask them about the symptoms, and just from that, you can fill out a mental state examination documentation. And it's very, very helpful because we need to really observe how the patient behaves once they come in, once they start medications, before they're being discharged, that sort of thing. And the mental capacity assessment is also very important. You have to do one every time you see a patient or every time a patient gets admitted. You also have to do one, for example, if a patient has a physical health concern and you need to send them to A&E and the patient is refusing, you have to document that this patient has capacity, for example. So yeah, like I said, it would go a long way if you just refresh those in your mind before starting your psychiatry placement. Okay. There are also some other psychiatric facilities that are a little bit different than medical wards. So, for example, we have seclusion rooms and de-escalation spaces. So seclusion rooms basically is for patients, and they're very common on PICU and forensic wards, are for patients who are behaving very aggressively and they are causing either a harm to themselves or a harm to staff, a harm to other patients. So when we've exhausted everything, when we've exhausted verbal de-escalation and that sort of thing, sometimes we have to seclude them in a room. This room is usually has a very secure access. It's usually padded, no sharp edges, no tools that can be used, to harm themselves or ligature, that sort of thing. And there are very strict documentation requirements and observation requirements as well. They have to be seen by a doctor every 12 hours. Again, I wouldn't worry about that. It will usually be explained very thoroughly in your trust induction, and you will find it in your trust policies. But basically, for seclusions, as a junior doctor, if you're on call, you have to see them every 12 hours, or every 4 hours if they haven't been seen by a senior, but that's not usually the case. Next, we have the 136 suites. I'm going to speak about that a little bit later when you speak about the legal holding powers. Observations levels, staff call systems. Well, like any ward, we have the alarms and alarms everywhere. If the patient is feeling distressed, they can press the alarm. If staff feels like they're in danger, they can press their own alarm. So yeah, ECT suites. So this is electroconvulsive therapy suites. They're usually situated in a general hospital, not on its own. I say that because mostly psychiatry wards are not placed within general hospitals and next to other wards. But for ECT suites, they usually have to be placed in a general hospital because it takes place under general anesthesia. So you would need that anesthesia and medical support. And like any ward, we have our clean utility room where we have ECG machines because it's very vital to do ECGs because our bloods are very nasty, known for causing all sort of ECG changes and QT prolongations. We have blood taking kits, medications, that sort of thing, urine analysis, drug screen strips, pregnancy test strips, sorry, that sort of thing. One thing you have to know is that we don't have any IV medications on psychiatry wards. So we can give oral medications, we can give intramuscular injections, but no IVs. We don't have fluid bags, we don't have IV cannulas. So you have to know this to know your limitation as a junior doctor. So that doesn't mean that you can't treat. You can always assess for conditions like infections and give oral antibiotics. But if you think the patient needs something through their veins, they're going to have to be transported to A&E, or if you're in a general hospital, to an acute medical ward. And we have our own electronic record systems. I'm not sure what other trusts use, but in my trust, which is the Lancashire and South Cumbria Trust, we use systems like Creo for documentation, EPMA for electronic prescribing, CETO for basically past documents for the patient, nerve centers for observation levels, and VTE assessments, that sort of thing. Again, I'm sure your local induction will cover these based on what systems you guys use. Okay, So in terms of physical health issues in psychiatry, like I said, we always need baseline investigations for new admissions because our medications are very nasty. We also need ECGs. You always need baseline ECGs for admissions. Um, you'll also find that psychiatry patients are monitored for weight gain and weight loss and metabolic syndromes very closely because our antipsychotics are notorious for doing that. So you'll find us weighing patients every week, taking waist circumference, doing HbA1c every 3 months, that sort of thing. And like I said, we're also very heavy on ECG monitoring. So you don't have to be super good at reading ECGs, but you have to know the basics as well, and you have to be very mindful of the intervals and their prolongation and shortening, that sort of thing. Um, we also do clozapine monitoring. So clozapine is an antipsychotic for those who are not familiar. It's very good. It's very effective, but it's very nasty. The monitoring and has really nasty side effects. But again, I'm sure this will be discussed and you're going to have a local trust policy. There is a national policy for clozapine monitoring that you can look up. But I'm just going to speak quickly about the complications that you should be aware of. But other than that, you'll be familiar with that on the word, so I wouldn't worry about it. Smoking, lifestyle, and poor nutrition, for obvious reasons in psychiatry, because psychiatry is like a holistic approach, like you guys know. And smoking does affect some levels of drugs that we use in psychiatry. So you have to monitor whether the patient has quit smoking or has taken up smoking because it does affect the levels of medications in their bodies. And obviously delirium infections and, any sort of complication that can happen in a hospital. So the next slide, I'm going to speak about common effects of psychotropics. So this slide looks absolutely scary, but I wouldn't worry about it. I just wanted you to remind you, to refresh you about the emergency or yeah, the urgent complications that you can face in psychiatry so that you can be aware of them during your on calls. So the most common two that we look out for is this one, the NMS, the neuroleptic malignant syndrome, and the clozapine-induced constipation. So, if a patient has any psychotics, typicals, and they've recently changed dose or changed the antipsychotic itself, it will cause symptoms like high fever and increased white cell count. I just wanted to mention this because sometimes when we see fever and white cell count in a patient, we immediately think infection. But if the patient is antipsychotic, you have to be wary of the other symptoms that can scream NMS because it's a very serious complication. And the patient actually, if you're suspecting it, the patient has to be admitted into an ICU. So just be mindful of that. Um, and then we have the clozapine-induced constipation. So it's very common that patients on clozapine experience constipation. So during an on-call, you might get called up by the nurse asking you to prescribe Macrogol or, um, any sort of laxative because the patient hasn't opened their bowels in 5 or 6 days. So again, if the patient has clozapine, you have to be very careful with it. If you think the patient has not opened their bowels for a long time, compared to their baseline, if I were you, I would go examine the patient, just make sure there's no obstruction there, no ileus there, examine the bowel sounds, that sort of thing. Other than that, if you're happy, you can just prescribe laxatives and, of course, hand over to the morning team to keep a bowel chart for the patient. The others, I haven't come across them myself. They're not very common. But you can, just for a refresher, like serotonin syndrome, clozapine-induced myocarditis, lithium toxicity, hyponatremia, QTC prolongation. So just like I said, you can just read through these just to make yourself familiar with the common complications in psychiatry. Like I said, our drugs are very, very nasty. So, one other advice I would give you is that during on-calls, you will get called up by nurses all the time to prescribe benzodiazepines if the patient is feeling maybe agitated or anxious or that sort of thing. Usually it's not an issue. They don't cause much of an issue, but I would be very careful when prescribing psychotropic medications, especially out of hours. During the day, the pharmacy team is your best friend. They're very good. They're usually very receptive in psychiatry placements to help you with anything you're not sure of. And I would say at the beginning, don't be a hero. Don't play with any psychotropic medications with their commencing, changing doses, that sort of thing. I was very comfortable prescribing any physical health meds because that's what will you deal with. The consultants will not really care about the physical health meds. It's usually your job to do to sort. So, for example, medications for hypertension, infections, that sort of thing. But when it comes to psychotropics, I would run it by the consultant or the middle grade first. Um, Obviously during the day. Out of hours, it's not very likely that you'll be asked, well, it's not likely, it's near damn impossible that you'll be asked to change anything in a psychotropic medication, apart from maybe prescribing a PRN benzodiazepine dose. So I would refuse to do any changes unless it's urgent and the patient needs to be taken to any, that's a different thing. But I would not change any psychotropic medications out of hours. So, when prescribing benzodiazepines, just always prescribe the lowest possible dose. Just be aware of other medication that can cause sedations, like for example, if the patient is on a sedating antidepressant like mirtazapine, that sort of thing. Maybe keep a safe space between the two doses. Yeah, I just ask the nurses to monitor for sedation. The nurses are really good with that sort of thing anyway. And It's unlikely that you're gonna do a very big mistake because we have electronic prescribing systems now, which is super awesome. They always give you warnings whenever you're prescribing something that interacts with something that the patient's already on. You can just go check the BNF and, make sure you're comfortable with the dosing. And if you're ever in doubt, you can always call the on-call consultant or the registrar. All the consultants and the regis during my on-calls that I came across were very, very helpful, very receptive to questions and very approachable, so I wouldn't worry about that. Okay, so sorry, I talked your ear off about medications, but it's just the most important bit, I think, about starting psychiatry to be cautious with those psychotropics. So let's talk about legal powers now, because it's a very important topic in psychiatry. We're not going to go into details, but I just thought maybe I'd introduce you to the different sections, so that you're just familiar when you're reading patients' notes. You don't just see a bunch of numbers and you don't understand what's going on. Just so that you're a little bit familiar. So again, a scary looking table. We don't need to know all of this. I'm just gonna talk about maybe yeah, well, I'm going to talk about all of these, but in brief, I promise. So basically, when patients are admitted, they can be admitted on three different types of sections. So they can be admitted as an informal. So informal basically means that a patient has capacity. They have a mental disorder that requires some assessment or treatment in a hospital setting, and but they have capacity, so they have agreed to be admitted. So the patient is here of their own accord. So that's the informal admission. It's not on the table because it's not a section. So that's one type. The second type is a section two, which you can see on this part of the table. So section two basically is when a mental health doctor assesses a patient outside of hospital. It has to be two doctors basically. That's not something you have to worry about, at least in the beginning. So when they come to you, the paperwork would usually say he's admitted on a section two. So that means the patient is admitted. That means the patient doesn't have capacity, most likely has not agreed to admission or does not even understand what admission is. And This gives you detaining powers and gives you also treating powers. So you can prescribe medications, you can start psychotropics, of course, with a consultant, but it gives you that sort of power. They're usually admitted for 28 days. So that's the only thing you need to know for now. Or they can be admitted on a section three. So a section three is different from section two in that it's a law for a longer duration, and there's usually a plan in place. So section two is basically patients being admitted for assessment. Section three is basically a patient that has a known diagnosis and they're being admitted for a clear treatment, a recommended treatment plan. There's not much difference in practice between two and three in the hospital, but it's just for you to be aware. So that's the type of admissions. So what happens, for example, if an informal patients, sometimes when we have informal patients, they want to self-discharge in the middle of the night. And When you assess them, as we all know, capacity is fluctuating. When you assess them, you don't think they have capacity, or even if they have capacity, you think they're too risky. They're talking about jumping off a bridge, that sort of thing. So you're not comfortable signing a self-discharge form. So what do? Well, you can use the 5-2. The 5-2 is the doctor's holding power. You can put any doctor above FY2 and above can put a 5-2 in place. It usually holds the patient in hospital for 72 hours and it doesn't give you a power to treat. It basically, I mean, you can treat if you'd like, and if the patient is happy to take the medication, that's absolutely fine. but it doesn't give you any powers to treat against their wishes. And you just basically hold them, for example, like if it's a Friday night, you're basically holding them until they can see the consultant on Monday, that sort of thing. And sometimes if the junior doctor is not available, because in psychiatry sometimes we do cross covers, so I could be, say, in Ormskirk and cross covering a ward in Preston, which is a 1 hour away. So, say if the junior doctor is not available and the nurses are not happy for the patient to self-discharge, they can use their 5-4 holding powers, which is lasts only for 6 hours until a junior doctor can come and put a 5-2 in place. So that's basically the gist of it. The last thing I'll explain is the 136. Oh, I forgot to say that 5-2 and 5-4 can only be used if the patient is already an inpatient in the hospital. So you cannot use a 5-2 for a patient who's an A&E, for example. They have to be admitted to a psychiatry ward. Okay, so 136. 136 is basically when a patient is a menace to the community or is a risk to themselves in the community, and the police, for example, you know, went to their house, picked them up, and they want to put them in a place of safety, so they can admit them to a 136 suite. So a 136 section basically allows you to hold the patient for 24 hours in the 136 suite. 136 suites are usually in psychiatric hospitals. They are not on the ward. They have a different access. I mean, they're usually ward adjacent, but they have a different access. And it's a secure room with a secure access, with a bed and a bathroom, and like I said, some padded surroundings. Yeah, like I said, your role as a junior doctor in this for a patient who's in the 136 suite is just to go see them, maybe take just a little bit of history and examine them physically, just to make sure that they are physically safe to stay in the suite for 24 hours. And obviously you can do a little bit of a mental state exam and a mental capacity assessment, but you don't have to do the full curriculum. So that's basically your role in the 136 suite. Um, so yeah. That's all for the sections. I'm sorry, I know I've thrown a lot of information at you, but I promise it's just a little bit of an introduction. I guess it's going to help you understand what's going on a ward. Before we move on, because this bit was a bit dense, do you guys have any questions that you would like me to answer about this bit?
Sorry, Manar. Someone was just mentioning, can you quickly, I mean, it's going to be a lot to ask, but can you go
That's fine.
quickly through the sections again a bit slower?
Oh, yeah, that's absolutely fine. Yeah, I
Um,
can do that again.
quick summary for us, if you don't mind.
Yeah, so basically a summary for you to know when a patient is admitted into a psychiatry ward, they can be admitted on three types of admissions. Either informal, which means that a patient is here of their own accord and the patient has capacity to consent to admission. Or they can be on a section 2, which basically means that the patient has no capacity, so they have been sectioned on a section 2 and they're here for assessment and or treatment. Or they can be on a section 3, which basically means the same thing, but it means that the patient is here for treatment. So for the sections, you have informal, capacity is intact, or section 2 or 3, in which the capacity is not intact. For you, as a junior doctor, you don't need to know much details about this other than, that the patient has capacity or doesn't have capacity. It can also give you a bit of background on how the patient is doing. Like if the patient is informal, you're gonna go talk to someone who's oriented, who's here of their own accord. So for example, if you're going to admit, if you're going to clerk an informal patient and you doubt that their capacity is intact, that's a big issue because that means they can be on an informal admission. So you need to call the consultant, that sort of thing. That's very, very rarely the case, but it's just so that you understand what everything means. So we spoke about the informal, section 2 and section 3. Is that clear so far with the three sections? Yeah. So, okay, you're most welcome. So, Syria, you were asking the difference between section 2 and 3. I think I already mentioned that, but just to reiterate. So, section 2 is a patient admitted for assessment and treatment. So we probably we're suspecting a diagnosis, but we're not entirely sure, so that's why they're admitted. Section 3 is the patient admitted for treatment. So we know what this patient has, and we have a clear treatment plan in place. Again, doesn't make a difference at all to you as junior doctors and during the on-call, so I wouldn't worry about it. Okay, so just to repeat the other sections really quickly. So as a junior doctor, if you have an informal patient, for example, that wants to self-discharge in the middle of the night and you're not comfortable with that, you have a holding power called the 5-2. So the 5-2 allows you to detain the patient for 72 hours in the hospital until they're seen by a consultant per se, or their section is renewed, for example, if the patient doesn't have capacity. You might need to use them, and if you need to use them, you can always call the on-call consultant, tell them the situation, and they will help you through the 5-2. It's very simple. It's a very short form that you have to fill, and you just hand it to the nurses to email to the mental health team. So yeah, the 5-4 is exactly similar, but for the nurses, so you don't have to worry about that. And oh, sorry about that. Yeah. And the 136, again, it's just a patient who is held in a safe place until, for example, if I had a bed for admission or until they're assessed thoroughly by psychiatry. Again, doesn't make much of a difference to you, but basically, you will get called to see patients in this suite, and your responsibility is just to physically examine them to make sure these patients are safe to stay in this suite. Also, sometimes you can also prescribe, like if the patient is on antiepileptics, you can prescribe those antiepileptics because it's a time-sensitive drug. So go ahead and prescribe that. Whether the patient takes it or not, it's not really your issue. What can you do if the patient is refusing, because you don't have the powers to treat, but you can prescribe it, and if the patient agrees, great. So that's basically responsibility in a section 136 suite. Yeah, Salma?
Yeah, so sorry, I just wanted to say, as we're all GP trainees here, the only section that's relevant when you go to community is the 136.
Yeah.
But as a GP, you'll be asking the police to go and do a 136. Other than that, on the long term, we don't really bother much with the sections. Just
Yeah.
we all need to know.
Yeah, so for GP trainees, like Selma said, sometimes if you have a patient who you think is a risk to themselves or risk to others, and they're not on any sections, they've not seen any mental health professionals, you can ask the police to go put the patient on the 136 section, take them to A&E or take them to a suite until they're assessed by relevant professionals. So thank you, Selma, for um, telling us that. Okay, let's move on. Um, All right, so those are just additional information that makes no difference at all to you, so I would just ignore the slide. Yeah. Okay. I think someone in the chat box asked about the mental capacity assessment, and I'm happy to explain it really quickly. Um, but I'll just go back to it in the end and explain it really quickly. I'm just quickly going through the questions I missed. Um, Someone asked, is autism dealt with by pediatricians? And well, Salma's already answered that. Thank you for so much. Okay, so about the rota and on calls. So uh, we've already spoken about your on-call responsibilities. Like I said, for example, doing the ward rounds as inpatients, the 136 suite, and out-of-hour reviews. But let's talk more about the typical structure of the rota. I have a picture of a typical rota. So let's just go to the next slide. So this is a typical psychiatry rota as an inpatient. So you usually do 4 nights in a row, and then you get the weekend off. And then, for example, the next week you do 5 normal working days in a row, and then the weekend off. And then sometimes you do weekends on calls, which is 3 days in a row, so Friday, Saturday, and Sunday. And then you get one day off, and then return to your base, and be it a ward or a community setting, doesn't matter. And for the weekend nights is basically the same. So you do 3 nights, Friday, Saturday, and Sunday. Uh, but after weekend nights, you get 2 days off. So you get Monday off, and then the Monday is the day you finish your night shift, and then you get Tuesday off as well, and then you return to your base. And usually with long day on calls, we don't do them like 4 in a row. We usually do 2 in a week, like as you can see here on this dark blue shaded boxes. So you, for example, you do 2 long day on calls in a week, and then the following week you do another 2. So that's how it usually is on a psychiatry rota. It might be different for other trusts, but this is how my trust does it. So yeah. So someone is asking about on-calls. I've been told that at time trainees stay at home but have a phone which can be used in case they are needed. Does that mean on-call shift don't necessarily mean staying on the ward at night? Okay, that's a very good question. However, that doesn't really apply to junior doctors. So when you're on call in psychiatry, especially if it's an inpatient, you are a resident. So you are resident on call. It's not non-resident. So you have to be there physically on the ward. You cannot be not on the ward because you are there for physical health emergencies as well. So you have to be there in person. However, other psychiatry trainees, like for example, higher specialty trainees and middle grades, they don't have to be there physically. They can be at home. They can be called if there is an emergency that a junior cannot be dealt with. Okay, so I can see some other people saying my trust is non-residential. I'm not sure what grade is that, but like I said, in the Northwest, that's not the case. Okay, so I can see some trust does that, so that's good to know. That's not usually the case though with most trusts. So I would expect if you're doing a psychiatric placement to do residential on call, unless someone explicitly says it's not. Okay, so let's talk about some challenging situations on a psychiatry ward, like for example, aggression and violence. So we spoke about this before. Some patients, they get very aggressive, they get very violent, they get even verbally abusive. So make sure to always carry your alarm. As a junior doctor in psychiatry, you would have an alarm. So make sure not to, don't be a hero. Don't go into reviews alone if you're uncomfortable. For example, don't go into the patient's room alone if you know this patient might cause trouble, or if for example, if the conversation is getting heated, make sure you have close access to the door. You can excuse yourself, grab a nurse and come back, that sort of thing. So don't be a hero. Always have your alarm on you because things in psychiatry can escalate very quickly from personal experience. And As for de-escalation techniques, so we can use several techniques. So first, we can use verbal de-escalation. We can give the patient some time to cool off. And we also have something called rapid tranquilization. So rapid tranq is basically giving a patient intramuscular lorazepam. So the nurses are very trained to do this. They'll probably tell you about the policy. They have to monitor the patient every 30 minutes for I think an hour and two after giving the intramuscular razepam, and they will be informed if the patient is sedated or something for you to come review them. So that's just one technique. And then if all fails, we can always seclude the patient if that is something we can do on the ward if we have a seclusion room. So we also have capacity disputes. So, like I said, mental capacity assessment, very important. Self-harm and suicide risk, always try to assess for these by asking questions, like we all know. So you can ask the patient, are you having any self-harm thoughts? Are you thinking? Are you getting any death thoughts of death? Do you have any plans? Patients are usually very upfront about it. It's rare that you would see a patient lying, but even then, if patient is lying, you would observe their behaviors on the ward, so you would have an idea about their self-harm and suicide risk. Also, you can always go through the notes of the patient if you're not able to fully assess them to see what is the historic risk of the patient. It's really going to help. Okay, and for delirium or organic mimicry, so on delirium, usually if the patient has delirium, they usually require urgent bloods. And because on psychiatry wards we don't have our own labs, usually we send the samples to a nearby hospital. So if any case you need an urgent blood, this patient has to be sent to A&E. You cannot deal with them on a psychiatry ward. Which goes the same for medical emergencies. If it's something you can deal with using the facilities you have, which is oral medications and baseline investigations and like observations in ECG, that's great. But if you think this patient needs, like heart monitoring, needs IV fluids, that sort of thing, you have to call an ambulance and you have to send the patient to the nearest A&E. So that's just something to keep in mind. Okay. So before I talk about supervision and career development, I'm just going to go back quickly and revisit the MCA because someone was asking in the chat box to revisit it. So basically, this is the mental capacity assessment here. Consists of four core pillars that you have to assess in order to make a decisions about this patient's capacity. So the first thing is that you have to make sure the patient understands the relevant information. This is very easy if the patient is already not oriented. So, for example, if you have a patient that's already disoriented to time, place, and person, then by default, they will not be able to understand the information you're telling them about admission, for example, about their treatment. So it automatically renders them lacking capacity. Yeah. That's the first thing. So if the patient is oriented and you talk to them about their diagnosis and they understand their diagnosis, they understand why they're being admitted, you have to, next thing you have to do is test for retention of information. Usually, if you're clerking a patient, you don't have to do this separately. It's because when you're talking to the patient, when you're speaking to them, you're revisiting the recent events, revisiting their symptoms, their sleep, their food habits, that sort of thing. If they're able to answer those questions, you can see very clearly that they can retain information and they can recall information from the recent past very well. So that's one thing. If you require an additional test for information retention, you can always use the three object tests. But again, like I said, you probably will not need it to do it if you're already clerking the patient because a conversation you will, through the conversation, you'll be able to assess whether the patient is able to retain information or not. Third thing you need to assess is using or weighing the information. So is the patient able to use the information to weigh, to make a certain decision? Um, So basically, if the patient understands their diagnosis and is still refusing admission, you have to assess the complications. So you have to ask the patient, do you realize that if you're not treated or if you're not admitted, the voices in your head can ask you to do something to harm yourself, that sort of thing. So if the patient is happy and understands that and still refuses admission or treatment, that means he's got capacity. That means he's able to weigh the information to make a decision, even if it's not a wise decision, but they understand the consequences, they understand the complications of the decision. If they're not, however, that means they cannot weigh the information. And the last bit of the MCA is the communication. So is the patient able to speak coherently, using spoken or even written language, if they have a disability, for example. So these are the four pillars. If only one of these pillars is the answer is no to it, then the patient lacks capacity. They have to be able to do all the four um, items very well to be rendered to have capacity. So this is basically how you assess capacity. So if the patient understands, can weigh the information, and can able to communicate, however, there's a problem with memory and they're not able to retain their information, then there you go, they don't have capacity. So that's basically it. Um, Okay, so there's a question in the chat box that says MCA seems to be a subjective one, which is very true. What happens to a patient who's just mute and just decides not to communicate back? So if you think the patient is oriented and they're just refusing to speak to you, you cannot just assume they don't have capacity. Like you said, it is subjective. You're just gonna have to go back and try again. And through their interactions, you would understand with the nurses, for example, with peers, you would understand if they're oriented or not. But yeah, if you're not able to assess capacity, you're just gonna have to put in your notes that you're not able to access capacity for so or so, for non-engagement, for example, that sort of thing. Um, or if the patient is, I don't know, delirious or that sort of thing, you're not able to assess capacity. I mean, obviously they wouldn't have capacity if they were delirious, but yeah, so it is very subjective and it's a bit of a tricky one, but you will get really good at it with time because you'll be doing MCAs 2 or 3 times a day on the wards, so I wouldn't worry about it. It's a skill you pick up really quickly in psychiatry. So any other questions about the MCA before we move on? I mean, we're almost at the end of our presentation. Okay. So this is the last bit I wanted to speak to you guys about, supervision and career development. It's mainly focused on psychiatry trainees. So I'm just gonna go through it very quickly because I've noticed we don't have a lot of psychiatry trainees um, in our presentation. So for GP trainees, you have your own, I think it's called self-development time. It's like an hour or two every week. But in addition to that, you also get clinical supervision, which is an hour every week as well with your clinical supervisor, who is usually a psychiatric consultant. This hour is very beneficial. It is junior doctor led, so it is your decision absolutely to do whatever you want in it. You can discuss a case, you can, ask them to help you with a certain skill you have, like for example, conducting an Adam-Brooks test, that sort of thing. So it's basically your choice on how to use it. You can use it also to sign off for place-based assessment, maybe take their advice on when to start exams, that sort of thing. And this also goes for psychiatry trainees. We get an hour of supervision every week. And also you have your educational supervisor, which is, so the clinical supervisor changes every 6 months, according to the placement, but the educational supervisor is the same throughout the whole training period. And also just be sure to keep a mindful, plan as to what to do with your portfolio, what kind of assessments you need. Try to fill in as much reflections as you can because you will encounter a lot of interesting, events on psychiatry wards. So make sure you reflect on them a lot. And as for MRC psych exams, I'm not going to get into them into detail. If someone wants me to speak about MRC psych exams in brief, I can do that. Just let me know in the chat box. Okay, so these are some frequent questions from previous trainees. Yeah. Um, uh, Common question is what if I don't know what to do? Well, like any other word, just call you senior. Don't be shy to do that. Most psychiatry seniors are very approachable in my experience. Can I refuse to do a section assessment? Yes, you absolutely can if you are uncomfortable. However, at a junior level, you will not be asked to do a section assessment. You'll be asked to do mental capacity assessments, for example, for patients on the ward. Unfortunately, you cannot refuse to do an MCA if you're the only doctor on the ward because this is a part of your job as a doctor, even not even as a psychiatry trainee, as any doctor, really, any doctor can do an MCA. So this is something you cannot refuse. So just make sure you practice that a lot. How do I stay safe on call? Like I said, always keep your alarms on you. Don't be a hero. If you're wary about seeing a patient on their own, grab a chaperone, grab a nurse. What's the scariest thing I'll probably see? Probably aggressive patients, psychotic patients, patients who are physically abusive. So just be careful. However, you're going to be having a whole team on the ward, so don't worry, you're never going to be on your own. And always keep a distance if you're worried. Will I ever actually use my stethoscope? Yes, you will. Not as commonly as you do on medical wards, but you will. Like for example, we talked about the clozapine-induced constipation, so you need to examine bowel sounds. If a patient is coming up with chest pain or coughs, you're gonna have to examine their chest, so you will have to use your stethoscope. So please get your stethoscope with you on the psychiatry wards.